Okay. Okay, well, good afternoon, everyone, and welcome to the first Health4Her seminar for 2022. For those of you who don't know me, I'm Amal Khoury. I'm professor and the chair of Health Services Management and Policy and Director of Care Women's Health, and I am delighted to welcome our distinguished speaker, Dr. Chloe Bird, for the 2022 kickoff of the Health4Her seminar. A tireless women's health champion and a brilliant researcher, Dr. Bird has dedicated her career to advancing women's health and the science around sex and gender differences in health and healthcare. I had the pleasure of working with Dr. Beard many years ago to establish the Women and Gender Health Interest Group within Academy Health. And later, I watched her closely as editor of Women's Health Issues as she took the journal to new heights and established it as a leading journal of women's health nationally and across the globe. So yes, I have witnessed firsthand Chloe's leadership skills, her ability to bring people together, and her incredible work ethic. Dr. Beard is joining us from California today, where she is a senior sociologist at RAND and professor at the Pardee Rand Graduate School. We hope to bring her to our campus soon, but for now, she is with us remotely to share her recent work on the impacts of increased funding for research on the health of women. And Dr. Beard asked that please type up your questions. We will have time for Q&A later this afternoon. But if you have any question, that you feel you need to ask or get clarification about during your presentation, to please raise her hand, and she'll be happy to answer questions during the presentation as well as afterwards. So thank you all for joining us. Thank you so much, Chloe, and I will turn it over to you.
Thank you. It is a pleasure to be with you all today. And I'm going to be trying to do this talk today without notes because I'm giving a shorter version of it tomorrow to the Reagan-Udall Foundation for the FDA. So I'm a little anxious about that one. But today we'll have the luxury of a lot more time to discuss. So definitely, as questions come up, drop them in the chat. If you have something that you want to get clarification on quickly, raise your hand as well, and Molly will monitor the chat. So this is interesting project on the societal impact of increasing research funding for the health of women. And what I'm going to present today is from our team. It's a large interdisciplinary team on a, as these usually are, a small budget project, looking at the how do we understand what would be the value of investing more in research on the health of women. This project came to us from Women's Health Access Matters. There's a group of business women who were interested in making the business case for investing in the health of women. As health researchers, which I think most of you, if not all of you are, or trainees, you probably understand that it's not a given that investing in something to improve health saves money. The medical students are always surprised at this. The things we do that improve health mean people live longer, typically with some disease or get some other disease. So most of the interventions that we are so appreciative to have don't make a healthier society. And I apologize, my dogs now want to be in the room. Hopefully my sons will attend to that. So it could be the case, as they found with Eastern Europe in looking at, we knew smoking causes early death. Societies couldn't necessarily just eliminate cigarette smoking and have a sustainable model because of the healthcare and the costs of people living longer. And economists certainly got nailed for pointing that out. But so here we're interested in the question, could we improve women's health? Could we do research and have an impact on women's health and save money? Well, why don't studies include more women? We certainly have a long history of research being based on men, studying either exclusively or primarily in men, and then including some women and generalizing to women as if we had studied them. In 2004, we found that 43% of the studies enrolled some women. It was only 38% in 2009 and 46% in 2015. We do see a growing percentage actually analyzing the data. That in itself is huge progress. For most research, we just throw in a bivariate measure and pretend that we can generalize across. We pretend that we have an underlying correlation matrix that's the same, which is a kind of an odd assumption given all the evidence that we don't. As a result, we have a great deal of difference in what we know in terms of the evidence base on the mortality from within a year of a heart attack is much higher for women. Now that's not surprising. We specialized in understanding heart attacks in men for a long time because they happened earlier. Those models are different from what heart attacks look like in women. The overall health of those men is different. And our ability to treat them. All of the models are overfitted, if you will, to diagnosing and treatment in men. They don't turn out to be nearly as effective they aren't effective at all in diagnosing microvascular disease that turns out to be prevalent in women. And they aren't as good in treating them. We can't go do balloon angioplasty all over the microvessels. But we see the same problem on prescription drugs. We see much higher side effects in women. It's long been understood, and it's been used as a reason not to study women. This becomes a problem because women have multiple comorbidities, far more so than men, so they're exposed to much more polypharmacy. And then we don't have the medications that were necessarily designed to treat them. So Women's Health Access Matters stepped in with an interest in looking at and making the business case across 4 pillars of health that there would be an advantage to studying women's health. And they came to us for some economic answers. So we're interested in the impact of health research and how the investment would could lead to better outcomes. Their 4 areas are brain health, heart disease, immunology, and cancer. Today, I'm going to go through the whole model on the Alzheimer's disease and related dementias, the disease we picked in the domain of brain health. And then I'll tell you about the results for the coronary artery disease and for rheumatoid arthritis. And I think we still have one briefing yet to go with a key audience on lung cancer. Also, these slides are going to get shared next week with our board of trustees. So you really are, although some of this is available on our website, you're at the front edge of this work coming out. Let's see. I think I've just talked through more of this. So we're interested in looking at it from a variety of perspectives, taking into account that there's a societal impact, there's an impact on caregivers, and there's an impact on the individuals who become patients themselves. And so trying to take a multidimensional, a 360 approach based on a wide range of existing data. So here we're talking about making a business case, making a model that takes into account what does it cost to have the diseases happening in the first place in women and in men in the current status in the US. Right now, 12.7 million people 65 and older are predicted to have Alzheimer's or related dementia by 2050. That cost is projected to be 355 billion total for 2021. 257 billion in addition is unpaid caregiving. Here to come up with those numbers, like you look at the cost if you had to pay the people, and that's mainly women as well who are doing the unpaid caregiving. So it is a huge cost to society for these diseases that cause very high rates of disability. Now, the impact on caregivers includes the lost income, clinical depression, quitting work, many of whom are out of work long enough that it impacts their careers. Men are much more successful than women at going back to something on par with or closer to what they left. For women, this is often a permanent sidestep, whether they were very young, caring for older parents, or older and pushed into an earlier retirement, which is really a retirement to a caregiver role. It also ages these individuals very heavily. So the existing policies require that we collect data on male and female individuals. And yet women's enrollment has been lower than men's. We're not seeing the numbers. This is supposed to be the same years on the columns on the left as on the right, 2004, 2009, and I think it's 2015 again. But we see this pattern that I was showing earlier, that we aren't doing the work. Now, we did, in order to address this question, we did economic microsimulations. What that means is we took existing data on the population and on the healthcare costs, and we projected out. We assumed a 30-year time horizon. So we're interested in what's the return in 30 years. We actually said we're going to assume it takes 10 years to have any impact, and the benefits show up from year 11 through year 30. We looked at the impact on health outcomes. We looked at healthcare expenditure data. We looked at labor productivity data, and we looked at quality adjusted life years. So we assumed that we were spending 1 year. This is all based on what would the return be on doubling the current investment in research on the health of women for 1 year, and how that plays out over 30 years. We looked at a series of outcomes. We assumed you could have an improvement that's a decrease in the disease incidence. In many of the diseases here, we're looking at a 0.01% improvement out of a 1 year investment. So well within, very, very low estimate of what's the return on the science. We looked at that same percentage improvement in progression, which assumes people spend slightly longer at the less severe stages of diseases. Now in ADRD, that's a little bit of a trade-off, because if you're not going into institutional care, then you spend more time at home or at a lower level of care, and each of those steps may require more unpaid caregiving. So you may save money in the most expensive kinds of care, but increase the unpaid care. We also assumed a better quality of life, that people had better, that same 0.1% improvement in quality of life at each of the stages of the disease. And so for the outcomes, we looked at health. We looked at the healthcare expenditures, we looked at caregiver labor productivity, and we looked at quality of life. So you could have years of life saved, you can have better functioning, you could have more people are able to stay in the labor force. For other diseases, we looked at patient productivity, but for Alzheimer's and related dementia, we just assumed we were starting at age 65, and that this is not taking people out of the labor force. When we change to another disease like rheumatoid arthritis, a lot of women are impacted in their 50s and lose time in the labor force. So there it would be cost of the disease itself. So for health improvements, I've already mentioned, we looked at these three outcomes. and the kinds of interventions, and then the impact where we see fewer nursing home years and changes in the overall healthcare costs. We looked at 3 models for ADRD. For a few of the diseases, they're a little bit less prevalent, so the 0.01% or 0.02% was not big enough given the actual numbers across the entire US population to have stable estimates. But here we're looking at that 0.01% improvement. For the data on health expenditures, we took the MEPS data on outpatient and temporary inpatient care. We took the health and retirement study data on the probability and cost of institutionalization, and we used home-based formal care, paid care from MEPS. For caregiver time loss, as I mentioned, we weren't looking at formal labor absences of the patient themselves. We use that in the other data sets, so the spaces here. And we looked at estimates from the MEPS and from literature sources on how much informal or familial care was required for patients at different stages by age, by gender, and so on, and by level of disease. And then we looked at quality adjusted life years. One convention, we had to make a lot of decisions projecting 30 years out. And as you're all well aware, females earn less in the labor force than males, and those of color all earn less than non-Hispanic white males. In order to not build that inequity into our assumptions, our estimates of labor costs are based on a white male salary. So that's that. In this case, because the costs are costs that occur in the face of improvement, this actually subtracts from any gains of less formal healthcare. That flips a little bit as we look at some of the other diseases. But we did not want to project out and assume that the gains and the changes over time are based on a static wage discrepancy. So that was a consideration we had from early in our analysis. Now, how much gets spent on research on Alzheimer's and related dementia? Well, in order to get an estimate of what's the actual bucket, we decided to focus on the NIH bucket because there's not, there we can actually bracket what work is done, how many dollars go in. And for NIH, for the most recent year, it was $2.4 billion that went into research on Alzheimer's disease and related dementia. And of that, based on our analysis of the NIH portfolio, 12% went to research that asserted it would be answering questions on women's health. It doesn't mean all the other studies didn't include women, but they did not describe that they were going to do this. It's possible that this is conservative, but if it were a very conservative estimate, we would expect to be seeing those articles published out in the literature, and it's not happening, as I'm sure you all are aware. Based on our initial presentation on this, the Office for Research on Women's Health went back and looked at across the entire NIH portfolio and found the average across all of the diseases and institutes was 11%. Of the studies addressed any questions on the health of women. So we have a almost blank slate to work from. Turning to our results. Okay, so the one other thing I wanted to say about that. So in this case, the doubling of the budget would only mean pouring in another $288 million. That would double the amount of money going to research answering questions on women for that year. So we're not saying that's all that should happen, but it's far more attainable than we would have imagined. So first, when we look at the investment, the impact on time with disease and time in nursing homes, and we see here we assumed that research that focused on questions of women would give a higher return to women than to men, but men would benefit. we would learn things that are helpful to men. That's been the model all along of studying men. We're more likely to learn something that's of help to men by studying women, because we haven't studied them. We're going to learn newer things. But we assumed, it's an assumption built into the model, what this ratio is. So this 0.01% gain would produce 2,862 life years, quality adjusted life years for women, and another 1,073 for men. It would save 5,545 years across the US population of living with ADRD for women, and then another 894 for men. This is because women live longer with ADRD than men. So that assumption of a 0.01% improvement for women, they get a bigger gain out of that, even though they're older on average. And then we see the gains in terms of nursing home years saved. Here we're assuming that the impact is 3 times as high on women as men. We could be less conservative. Then we looked at quality adjusted life years and informal caregiver productivity, and we see these just tremendous gains in QALYs across the US population of that tiny assumed improvement. Now the WHAM actually was appalled that we wanted to look at this small of an improvement. Here we're trying to make the business case, not by coming up with the razzle dazzle, fantastic, big, this could happen. What we're trying to argue is almost a worst case scenario. What can we assume will absolutely happen if we were able to make these small increases? This is even if that's how little the research yielded, this is the kind of gain that we would have. Here's that pattern I talked about in terms of productive years for caregivers in caring for women. We have it's a negative cost because they live longer at all of those stages. There's a shift between nursing home costs. For the men, they didn't necessarily live longer. You can think about it in terms of that might mean more likely you stayed at home and never got institutionalized, even though it's very small amounts of savings or gains. The big dollars come in as we start to look at nursing home costs. And here we see just fantastic improvements in hundreds of millions of dollars in savings in nursing home costs and savings based on QALYs. We valued a life year at $100,000 a life year. That's still remarkably low. The original target was 50,000. I think that was based on research in the 70s, and there hasn't been a new amount that the U.S. economy that we've come up with for among at least that economists have come up with. What this means is that by putting that additional $288 million into research on the health of women with Alzheimer's disease and related dementia, we would see over the 30 years, a 224% return on investment. That's in real dollars. That's adjusting for inflation over time. That's really fantastic. I mean, we talk about how if you could put money into preschool and have a net savings of 224%, where you've directly invested in the policy, you've directly invested in the program, that this return would happen. This is really amazing and exciting as a researcher that you can say that is how high the yield would be. And it's that high because there's so much we don't know. So what we see is that investing in women's health research can result in savings in healthcare costs. It can result in very small, large returns, economic returns from very small health improvements, but also large returns in terms of healthy years of life and years of life saved. And this can support a funding resource allocation. It can support changes in policy. And I've met with and talked at the NIH on the kinds of policy changes that could happen that would allow this. And there's a lot of lobbying happening in Congress. Let me see. Well, let me get to the end, and I'll see if I can pull up this other. I have another thing that has the graphs on the other diseases. There we go. Okay. So we're talking about societal impacts and overall. Let me see if I can stop sharing and then share the results for the other diseases. Share screen. Okay, so for coronary artery disease, we saw a little bit smaller amount of money going into women. The total amount is lower because for Alzheimer's and related dementia, we've had this 5 or 10 years of a doubled investment that Congress had approved. But so $1.9 billion went into coronary artery disease research. Only 20 million went into research that was answering questions on women. That alone is a showstopper for me. But what we found, because those coronary events, that disability overlaps with time in the labor force for women as well as for men, we see a 9,500% return on investment for those dollars. That's mind-blowing. I mean, I would like to invest in something like that. And the benefits accrue to the society. So it's really hard to make any argument for not doing it. I think in some ways more striking is the rheumatoid arthritis example. Here, a mere $10.5 billion go into this debilitating disease, 6 million of which proposed to address any questions on the health of women, to look specifically at women. And here we're talking about a disease that disproportionately affects women, that it's not just the differences in the diagnosis and the treatment, but we see very large impact on labor force participation and disability for the rest of their lives. And we found 174,000% return on investment. 1,740 times what went into it would be yielded over 30 years. So this is making the case. We're presenting to these different, the American Heart Association, the different leading brain research groups, the specialized funders. We're working with the American Lung Cancer Association and other leading groups. But we're trying to play this into a conversation that we should have been happening for a long time, that if we do research based on a narrow subset of the population and then pretend we can generalize to everyone else, we don't come up with answers that fit everyone. Now, my personal commitment is we didn't come this far to do research that is then just about high SES white women. The whole point here is that the research that we start to look seriously at where the disability occurs, at who is having differences in results, and we start to recognize that those are the opportunities for advancing the science. That's where we should put more money. Currently, NIH tends to treat, and it's because of the review process in large part, doing a study in a different population as a mere replication and not an advancement to science. So one of the kinds of policy changes I've recommended is that if we would be studying something where it hasn't been studied, in a group that has not been assessed, or an intervention and taking it to a population that has not been studied, that would have to add to the score on innovativeness. Right now, the innovation score steers heavily towards, do you have the sexy new lab technique, and not, is this innovative work that would advance the science into something that we don't know? And similarly, that if the work would be in an area such as this, that we would have to actually assess it as making a contribution, as high impact. And NIH has adjusted their scoring in the past to spread out scores, to try to correct and streamline how many types of weaknesses are in a study, we could address this anomaly or bias where the scientific field as a whole tends to collapse the difference between where we have an evidence base, an actual gold standard for research on a subset of men, and then generalize to women and everyone else as that women are getting good enough medicine and men are getting evidence-based medicine, and we can change that. And I'm arguing that at the areas where we do new research, where we actually address, does this work generalize beyond the kinds of populations that have been studied in the past? That's where we're going to understand the limitations of what we know. That's where we're going to understand the difference between things that we know by evidence and things that we know by agreement. And that's where we're going to learn what the limits are and what else is possible. So I think that covers everything I was hoping to get across. And I'm happy to entertain questions. Oh, thank you.
Thank you. Molly, I guess, I'm not sure that I can see the chat. Well, I think I can. I'm not seeing the questions in the chat.
Yes, I saw Kathleen and Jordan both raise their hands. So if you guys would like to just unmute and ask your questions, Jordan, you can go ahead and go first.
I was just clapping. I didn't have a question. I was applauding.
Thank you.
Thank you.
So Chloe, I will go ahead and I guess, get the conversation, going. So,
Thank you.
So this is obviously, very interesting, especially, for us, I guess, who have been trying to move, the women's health agenda for decades now. Right? Mm-hmm. And so, I'm trying to make sense of how has the funding, particularly and the NIH funding opportunities, how they have evolved and what has that meant for science. So back in the 1990s, you will recall when the Office of Research on Women's Health was established, within the NIH, one of the main focus areas was increasing women's participation in the research, right? It was at that basic level, because again, at that point, most studies just did not include women. Right? I mean, they were, excluded, and there was no justification for that exclusion. And again, the policies were developed at the time to where, unless there is very, very strong justification, both men and women should be included. So we moved into, I guess, a phase where NIH studies were including, both genders, but not necessarily analyzing, their data or designing their methods to be able to answer questions that are specific or sensitive to women and men's needs. Is that a fair assessment in your opinion?
Yeah, I mean, basically, if you think of a policy change, often is realized in the way that makes the least fundamental impact. If you imagine, you've got a huge machine and you move something and you just turn the Venn diagram just far enough to capture that, to check that box, but not change everything. So in one sense, the biomedical model is still treating people like if we need to do a study in 100 people or 1,000 people, it really doesn't matter which 100 or 1,000 we get. Unless you wanted to study it in a hard to treat population, either because they're extremely stressed, they're extremely frail, they have comorbidities, or they are truly disadvantaged. And that actually becomes a self-fulfilling excuse for not having results in those populations and for avoiding including them. But the data, I mean, at certain points, data was collected on women or on female animals and then just discarded. It wasn't even analyzed at all, much less because they were getting different results. And then the justification was, we know what's going on, and there's just too much noise in the data on females because of hormones or whatever the explanation happened to be at the time. But it was that we know, and we don't even have to study it to know, which is a fantastic view for science to take. What was mandated was including more women. They started including more women and then controlling for the fact they did so and proceeding as business as usual. Now, the irony is that means we end up with less precise information on men as well. It's better than the information we end up with on women because the assumptions, everything that you're holding it to, the models that you're testing, it is a house built on stilts, but those stilts were based on data on men. And it's pretending that it's not on stilts. What's going to have to happen or will occur as a secondary effect of starting to look systematically at how and why we get different results across gender, across socioeconomic status, across racial ethnic groups that have very big differences, is we're going to have to start to understand that people aren't interchangeable carbon atoms. I mean, we don't even treat it like you could substitute a different kind of mice in a study, but we treat it collectively as if we could study men and generalize to women. I mean, if that were true, the answer would be as easy as, well, let's study women for 40 years and catch up a little bit here. If it was good enough, it was truly good enough. If it was truly a benefit protecting women from research and you got good enough answers, then it would be absolutely okay and free to just shift and study women. And then we'd get back to studying men later in 40 years or so. I don't actually think that's true. I don't think that we need to go there, but I think that these numbers indicate how severely underinvested the US is in research on human health. Given the disease and disability that accrues over the life course, given anywhere where you see this kind of unmet investment opportunity in improving the health and well-being of a population, you've got to argue there's extreme underinvestment.
Thank you. Thank you for that. It's a very helpful and informative, perspective. Again, especially coming from, someone like you, Chloe, who has been examining, these issues, again, over many, many years, and I guess consistently coming to these same conclusions. I think there's a question from Dr. Orimai.
Oh yeah, thank you, Dr. Thank you, Dr. But thank you so much. I really enjoy your talk. I was going to ask if you've extended your simulation analysis to sort of show us the cost savings in terms of prevention or rehabilitation, and not just the big picture. Because the big question, because I work on ADRD a lot. Yeah, and the big picture is like, where do you come in? What can you do? But we all know that the continuum of the disease ends up in dementia anyway. So where do you come in? So I'm thinking if you can show the policy makers that this is where we should spend more, to see the greatest impact, I think that would be very, very beneficial.
I agree. And that was one of the first questions I got asked in presenting this to the Coordinating Committee for Research on Women's Health at NIH about a year ago. Now what do we do? I think we actually, it's an empirical question. Whereas this we could do without looking at how the machine works, what levers are producing what results. We're just looking at the total cost of a disease, where if you took out those costs, people would be subject to the costs of aging as they were without that disease. To to get at the costs for and the returns on types of interventions, we'd actually have to look at disease-specific data on what has worked and what hasn't worked. And those would be some fantastic and I think highly illuminating types of illustrations that we could do disease by disease. We would need to get big pharma data, for example, looking across all of the clinical trials and so on. We also would run into some distinct challenges because there's things that are done on a research basis, and that's what we'd really want to be getting at, and things that shift in practice rapidly outside of that and affect the standard of care. So I think that's going to be much more complicated, but it's something we're certainly arguing that we would like to take on. And of course, that gets us to everyone has a disease they'd like to study. Not necessarily based on our own research, based on our concerns, based on the things that matter in our lives. I'm very interested in what we'll understand about lung cancer. I lost my spouse to lung cancer recently. And he'd worked in this area for his entire career as well. So there are a lot of ways that we could go in bringing money to the table and looking at questions. The other thing I'm very interested in is how we can look objectively in other ways, including through systematic reviews, and start to measure why we don't know what we don't know. There's a difference between there's no evidence of sex and gender differences. And we've done a literature review of 10,000 studies and 3 asked the question. Now there's a difference in not having any idea because it's systematically not asked. And there actually being evidence that there is not a difference. And so we have a great deal of what we don't know that we need to capture to help to understand where to invest the dollars best. So we were just assuming that the dollars would go in some generally similar way to what's already happening. And I'd like to look at that further. Then one more area that I'd like to look at is this is all focused on areas of disease that impact both men and women. And we could obviously do this on areas of disease that almost or exclusively impact women, whether that's breast cancer, which is very, very largely in women, osteoporosis, very largely in women, but it is a huge, we understand so little in men about how to treat osteoporosis and osteopenia. We don't have any good interventions. And it does happen to men, those men who experience osteoporosis or osteopenia are at tremendously high risk of death with any fall because they can't recover. And you also have those damages happen out of some kinds of cancer and other aggressive treatments. But the area that's most on my mind and probably on many people's here is to look at the return on investing in research around maternal morbidity, maternal mortality, investments in creating the continuity of across the life course such that we actually would be capturing data, capturing and understanding what happened in someone's pregnancies and informing their healthcare for the rest of their lives, because that is so slipshod, not automated, that we still bizarrely treat pregnancy in the US like it's plug and play, and you're pregnant and stuff happens and you survived it, so ollie oxen free, even though we know that within 7 years most of the individuals who had gestational diabetes will have diabetes. We know that they're at increased cardiovascular risk. But we don't do anything to incorporate it into their records, to change their health over their life course and so on. So I could talk about this all day. Are there actually questions? Thank you very much, Dr. Ormai. I hope I said that properly.
That's correct. Thank you so much.
Thank you.
Hi, Chloe. This is Nathan. Good to see you again.
Good to see you.
Wow. Which everything is in a time warp anyway, so it may have been longer than I think it has been. But this is a question I probably should know the answer to. But I'm just curious about the caregiver component because, you know, I think some of us have reached a certain phase in life where we're staring down, you know, trying to provide care for our parents that are aging and kind of experiencing some of these things. But I'm just curious, like what's the overall prevalence of caregivers that actually leave the workforce for reasons related to this?
Oh, wow. You know, it varies on so many factors. Whether one, the kind of resources you have as an adult child or as a spouse, the kind of community you're in and the kind of resources you can marshal, and the disease state and trajectory. So, and then all of it has shifted under COVID, where I think that it shined a light on how much caregiving goes on and how complex it can be. So I don't have the percentages, even on a disease by disease basis. I have the academics of disease. I'm not going to come up with a number I don't have a citation for. But it is very common over the life course, especially for working women, to be engaged in extensive unpaid caregiving, and across a family system of some individual, and it is usually a woman, having a leave from the labor force, combining it with extending a leave from the labor force, or an early retirement around caregiving. I think we'll end up with a lot more data on those early retirements around caregiving, as so many households had to consider the risks of bringing something home, and that shifted the balance for a lot of people. We've definitely seen in the employment data that labor force exits around retirement, which is mainly where we've lost people in the labor force. That's more than 80% of the changes in employment, have happened somewhat earlier, and those are always, we call it sticky, less likely to come back in than people who left for some other reason. But in specifically, we're seeing it stickier. We're seeing people being even more unlikely to, sorry, I've got a adult child coming in to get a power cord. It's all about the power cords. But we're definitely seeing this impact that I'm concerned about the sequelae, because depending on what happens to the economy next, I'm not terrified about the economy, but I do worry about what happens demographically across populations. If we see a reversal of the kinds of gains people have made that could sustain their retirement at this point, or they're based on their home values and so on, we're going to have a lot of people who left and can't necessarily get back in and work. So I'm concerned about it. But the data, like if you look at the data on the sandwich generation, people who are caring for either kids and parents or a spouse and parents, that number is low, but the likelihood that you're doing it at some point in your life, and that at some point it becomes severely demanding, is high. Ideally, I'd like to get data on where careers flatline in that as well. Where people, just can't push forward, whether it's to go for another level as a faculty member or sustain what they're doing, or they take a step off of a track towards career advancement or to something that's simpler and more manageable in the face of the kinds of demands they face as an unpaid caregiver.
Thank you.
Really good to see you. Hope we're back on stage together again soon sometime.
Yeah, maybe. I don't know.
Could happen.
And there's another question in the chat from Dr. Wani Manilu. And the question is, on the salary estimation for the lost time, your numbers were based on income of white males. Was that because you had no reliable data on other races? Wouldn't that overstate the ROI given whites have higher average incomes?
We had to make a call. No, it wasn't because we lacked data on wages. We do have sufficient data. We're basing most of this on like the cases, the data on the Medicare population, for example, and the people are caring for them. RAND works with the 100% sample. It's still called a sample, not a 5% or 1% sample of the data. We've got, and the Health and Retirement Study and other studies, we've got, to the extent that anything is knowable about the US, we have extensive data. Yes, we decided it's better to err on the side of overestimating than underestimating for the reasons mentioned, not being willing to say we'd save less money because paying women is worth less. That wasn't something we were willing to build into the model. However, in the case of Alzheimer's and related dementia, it doesn't cut into to the extent that it's a higher statement than what today those dollars might be priced at, because of the savings of sexism and gender inequity, or racial inequity. Those overestimates, I guess you're considering it, of costs are counted against the savings. And that's true in any of the times where those costs are on the side of the caregiver, not on the side of the patients themselves. The place where it would overestimate the costs, the return on investment is saying that the patients themselves would be earning a higher wage than they might be earning based on their race or gender. So it's a pretty small amount of the data overall as well. I mean, most of the savings come out of hospitals, and this does include the cost for men, and includes both types. But we weren't willing to buy into inequities as part of the evaluation. Probably in one of our reports, there's a footnote explaining what it would look like otherwise, because they're long. What else would people like to see? If you could look at this another way, if there was a disease, if there was something that you could look at, what would you want us to be answering?
I mean, what you mentioned around maternal morbidity is very intriguing.
Mm-hmm.
Chloe.
Yeah. Well, I'm very interested in getting at the long sequelae of maternal morbidity, and how that contributes to racial and socioeconomic differences in health, because those things are cumulative and occur, and have been so much ignored. I really get excited about problems that we have stepped over every day, and where can we bring data to say this is expensive. And what's expensive, what's shocking here is not that there could be this high of a return on investment. This high of a return on investment is possible because this is the price of doing it wrong. This is the price of generalizing. And that's how much it costs. It costs so much that improving 0.1% in generalizing, or in the case of rheumatoid arthritis, 1%, a 1% improvement in that would save us billions and billions of dollars.
I guess, how hopeful are you that, this important work is going to translate into policy change within the NIH?
Well, I think we're at a time where a lot of change could happen. We're having a change in who's the head of NIH. It's leading to a lot of discussion and panels, and taking up a lot of time on a lot of committees for me, looking at, does this mean we ought to have an office, go from an office to an institute? The problem with going from an office to an institute is it stays as a new column, as a new isolated piece. And this solution here is not about having a separate silo that looks at women's health. But so it's certainly affecting thinking. I am in some ways an eternal optimist that if we can make the case, because I don't believe scientists intend to be biased. I think they just have an incredible amount of myopia to over focusing on the data that's there and not understanding the implications of the data that's not there. And if we can leverage this into some change, because we've seen area after area flip to studying females. The work looking at the biology of aging and are there pharmacological interventions that can drastically slow or reverse aging. That work is done in rats. And it turns out almost all of the interventions, like 5 out of 6 of them as of several years ago, only worked in female rats. And all of a sudden, no problem. Everybody's studying female rats. I gave a talk on this about 5 years ago and had I love him to death, senior researcher get up in the audience and tell me in front of everybody that this was true and it was good that I was interested in it, but we now study women in everything and there's no problem anymore. This is all completely handled. And I was like, thank you. I'm glad that that is true in your part of the world. We're a long way from there, but because we can make change by creating those tipping points, I think that that this is winnable, that we can make a drastic difference. And every time that we hit another tipping point, every time that we have people get higher up in leadership roles who understand that the opportunities and the returns on studying women are higher than business as usual, then we make a change. So I think that this isn't going to look like a linear progression. It's gonna look like it's accelerating. And so, let's stay tuned.
That's very, very exciting.
The one thing I tell my students, though, is this is where breakthrough science is going to happen. It is far more likely that you get breakthrough results, that you find something big, sexy, different that puts your work on the map and that has an impact if you study the health of women, if you study the health of minority populations, if you study where the disease and disability happens. If you can articulate it and make the case why it matters and what it will save, that's what's going to make a difference. And I think as soon as it's clear that that's what gets funded and that's what gets awards, we'll have the same problem that we're having right now in research on racial disparities, where the white men are elbowing everybody out of the room to continue to run the table. And that brings other problems, but I'm willing to deal with that too. So thank you all for your time. I really, really appreciate it. And I look forward to the day I can come and meet you in person.
Thank you, Chloe. There was one final question, but I know we're out of time. So
I'm happy to stay, but.
Okay, so if people need to, leave, of course, please go ahead because it's 1 p.m. But just since Leanne went ahead and typed, her question. Her question is, first she thanks you for the amazing work, and then she says, can you speak about how this type of methodology can result in precision medicine and public health practice for various outcomes?
Well, so part of what I'm really interested in is how we move back and forth between what we know from clinical intervention studies, clinical observation studies, the silos that work has happened at in medicine, which are narrowed and shaped in different ways by what disease is recognized and what treatments are given and all the policies and impacts. And then on the other side of the table, which is more where my work is, what's happening to the population? What are people dying of? What does disease look like? And where those things don't line up. And so right now I'm working on a proposal to look at total knee replacement and how we haven't looked at very much how that works in women. We've got the most prevalent, expensive surgical procedure done in the Medicare population and overall, and it's going like gangbusters. There were hardly any minorities in the observational data. that had been studied for decades. And that's because of not having the same healthcare coverage, not having the same access, not having other people that you knew who'd been through it and come through it well, not necessarily being the kind of people who come in and demand the treatment, which got seen as an appropriate filter for who's a good candidate, as well as things on body types and what would be the most appropriate for achieving good outcomes. So women would get treated later than men. We're only a few years into actually having any knees designed specifically for women's bodies, which you might have noticed are smaller. You know, I mean, there are all of these things your 3 or 4-year-old could tell you about sex and gender differences that seem to be missing from some of the medicine. So I'm very interested in where we can map back and forth and talk about what do we don't know and where we would get different answers if we look at what something looks like in the population as a whole than in the clinical work and start to get there at informing precision medicine. Because if we can't tell you what's how care actually would work in women, the idea that we're going to customize it to you is quite bizarre. I'm really sorry. My dog knows time. The dog opened the door. All right. Sorry. On that note.
But it's time for the dog, you know.
Yes.
Okay, well, with
Apologize.
that, no problem at all. Thank you again for staying on, you know, for a few more minutes. Thank you, everyone. We really enjoyed, you know, your presentation, Chloe, and you may not be able to see, I don't know if you can see all the comments in the chats, but everyone is sending, you know, words of thanks and appreciation for the discussion and the excellent, you know, work. So thank you again, and we'll stay in touch. And yeah, hopefully we will have you here in East Tennessee in the near future.